Welcome to another space hosted by DIAG, Democrats for an Informed Approach to Gender. I'm Ellie, DIAG's Executive Director. DIAG is a 501c3 nonprofit organization of lifelong Democratic voters. We're working to shed light on the medical scandal and the erosion of women's rights that are the direct results of gender ideology and sex denialism. We're building a movement to correct what has been the prevailing narrative around the experimental, dangerous medical practices of sex trait modification, what's euphemistically known as gender-affirming care. We're striving to clear the path for a safer, saner, evidence-based response to gender distress. Please visit our website at diag.org and also check out our merch store. And if you'd like to help us continue and expand the work we're doing, please hit the donate button. DIAC believes in the liberal values of free speech and open discussion. This is why we host these spaces, to invite conversation on topics that have been left out of the public discourse. The opinions expressed by our guests are not necessarily the opinions of our organization. Okay, how did our society come to endorse what would have been unthinkable just a couple of decades ago? Physicians are halting the sexual development and disrupting the normal endocrine function of thousands of mentally fragile young people. Surgeons amputate the healthy body parts of distressed minors who are too young to get a tattoo. Patients' first stop on this dark medical pathway is the therapist's office. There, they will find mental health counselors who are ready to affirm their declaration that they were born in the wrong body, and quick to refer them for irreversible, harmful body modification procedures. Our guests today are two therapists who reject the gender-affirming model. They will help us understand why and how gender ideology captured their profession. They're Jenny Rogers and Brooke Laufer, two therapists from Illinois who work with gender-distressed young people and their parents. Both Jenny and Brooke belong to an organization of dissenting mental health clinicians called Therapy First. They have bravely spoken up, at personal risk, about their colleagues' role in promoting medical malpractice and about what is needed for their profession to return to common sense. Welcome to both of you.
Thank you.
Thank you so much.
So we'll start with Brooke. Brooke, you've
Okay.
been a therapist for a number of years. So when did you start hearing about or seeing more patients reporting gender dysphoria or not being aligned with their gender? We know the
Mhm.
statistics. It was something like 4,000% increase over 10 years at
Mhm.
the GIDS gender clinic in England for girls, and
Mhm.
similar kinds of rises here.
Mhm. Yeah, I've been a psychologist for 20 years, but my focus has really been maternal mental health. So I wouldn't have seen as much of people coming in for gender, although I have a group practice where I have interns, so we really see all sorts of people. But it wasn't in the practice, it wasn't like a slow build. It was a sudden surge of mostly adolescents who were coming in, I would say around 2020, 2021, 2022, sort of peaked in the practice, and it's still going. It's still going. Um, Mostly young girls coming in, exploring their gender, identifying as boys, identifying as non binary, um, and everything in between. Yeah. So I would say it was really in the heart of COVID in my practice.
Okay, I think that kind of jibes with other experiences from therapists. Um, and what about the affirmation model? When did you notice that model for gender confused patients had become the standard?
Right. Yeah, and it wasn't like it was announced, right? Like there was no webinar or American Psychological Association being like, this is now what we're going to do. It was just happening. And it was sort of in retrospect that it was called the affirming model. Um, and basically, what that meant is just not questioning or challenging when a client, even an adolescent or a child client, was telling you they believed they were the opposite gender. And so it was just affirming the identity that they were stating. Um, and that seemed to surge right along with the clients that were coming in. It was as if that was just the response that the broader, collective of therapists were giving these patients. Um, and then came to be known as this affirmation model to sort of ground people's, with, like, clinical sense of integrity, like that there was a stated or researched way behind this when there really wasn't.
How did that get communicated? Like, what was the main way that that was communicated to therapists?
Yeah, that's such a good question. It was like in my memory of it, it wasn't communicated. It was that if you sort of knew that you couldn't challenge it. You knew you weren't supposed to say anything against uh, affirming these kids. Like, this must be what's happening. Like, everyone is now comfortable and coming out as trans. And so we have to give these kids all this positive validation. And you knew if you poked around against it, um, you were shamed, blamed, accused of being transphobic, cut out of groups, um, yeah, attacked on listservs, etc. That's sort of how I knew like this was now the standard.
Oh, okay. Jenny, you're relatively new to the profession, so you trained during this era of the gender affirming model. Can you tell us what that looks like? What's being taught now?
So I graduated my master's program in 2017. So I was in that program from around 2014 through 2017. And what was taught, I don't know if they used the word affirmation, but that's pretty much what was taught. It was seen as like a civil rights fight. It was compared to um, it was compared to homosexuality in that there used to be a time when homosexuality was considered a mental illness that was incredibly damaging to people. There were interventions that were incredibly damaging to people, and when I was in school, professors would talk about that, and they would talk about how we don't want a repeat of that. And so, when somebody tells you who they are, you believe them. And this was said even about children, and that didn't make sense to me at the time, but I never said anything because I thought these people must know what they're talking about. But what was taught was people know who they are. Um, Gender identity is very similar to being gay. It would be really damaging if you were to question this. Um, it would cause mental distress if you were to question this. And if people are telling you this, they're being very brave.
That may be all true, but then you're faced with these patients, these clients who are going to bump up against that. So
Hmm.
you didn't get the sense from even your training that that they were having to deal with this reality of it. It was just, this is what works. This is what we're recommending.
It seemed very much an exception to the rule. So, for example, if somebody were to come into my consultation room and say, "I have this problem with overeating, and I eat too much, and my weight is very high, and I have limited mobility, and I have this problem, and I want to work with it." As a therapist, I know in the back of my head, okay, yes, eating may be a problem, but there might be something else deeper. There might be another thing happening, and that tends to unfold over the course of treatment. And when it came to gender, there was this exception to the rule where we were taught not to look for that it would be damaging to do something like that.
So that's, the whole purpose of psychotherapy is to ask these questions and get the patients to explore and understand the reasons for their feelings. So
Hmm.
that this protocol kind of it bumps up against that, because you're there's it's almost like you're supposed to make this diagnosis of gender dysphoria before asking any questions about what's really going on with the patient. So how did the instructors square that with the historical role of the therapist?
I think they squared it because, at least in my program, there was a big focus on activism and advocacy, and this would be part of that. That, you know, part of part of the therapy world, in my professor's opinions, was working towards social justice. And so, even though this model of care is an exception to the rule when it comes to standard therapy, it was almost like we really had to look at our part in terms of a civil rights movement. Um, but it's not even just that the current protocol is a young person comes in and we diagnose them. A lot of times they're coming in self-diagnosed, and I remember being told in a class, trans kids know who they are. And I remember thinking, but a lot of people don't know who they are. And that doesn't have anything to do with whether or not they're trans or whether or not they're a kid. It's about being human. There are parts of ourselves that we deny, that we disavow, that we just can't look at. And part of therapy is helping people to integrate that. And there wasn't there wasn't I don't think that there was really a squaring of that. I think people are they're not willing to look at how this is very much an exception to the rule of typical therapy.
And if you add on top of that the layer that these are children, adolescents, young adults who
Hmm.
necessarily are not mature enough to understand the world and their place in it. So does the profession not take that into account at all? Uh, and we'll talk to maybe let's switch to Brooke on this.
Sure. Yeah. Yeah. I mean, the reality is that it should, right? We have decades of developmental psychology research and good theory and information and studies, but the affirming model does not take that into account. So, from a developmental standpoint, it's really well established that children, adolescents are forming their identities, right? Childhood is a time of bringing identity cohesiveness together, regardless of anatomy. Dress up and pretend is the name of the game, right? Up until maybe third or fourth grade. And then adolescence is really that time of exploration where identity shifts naturally because of social pressures. There's so much emotional volatility, and brains are just on really just in a mid developmental stage, right? They're not even close to being finished with development, particularly the prefrontal cortex, which governs that long term decision making, impulse control, and risk assessment. These are in nascent stages. So, for any other area of mental health, we would recognize that young people need guidance, they need the freedom to explore within very strong boundaries, but that nothing would become a permanent conclusion during that time. Yet, with the affirming model and our current state of gender identity, all of this research has been abandoned, and immediate affirmation is the norm, which unfortunately really arrests some of these people in early developmental stages. And we see that now with some desisters and detransitioners who are very arrested in development, very young for their age, maybe 25, but still at a age 15-year-old level because that's when they transitioned. So, because we've lost our guidance with developmental psychology, in my opinion, we're really harming a lot of these adolescents.
Are uh, you work with um, kind of psychologists who are new to the field? Do,
Yes,
and do you see that their training is significantly different? Can you get a sense that their training is significantly different than the training you had?
I do. It's strikingly different. Um, it's really up through the critical theory or intersection of oppression, lens. It's not as much the psychodynamic exploration therapist as neutral modality. So when I trained, which is of course many, many years ago now, we were really just focused on curiosity, exploration, helping clients making meaning of their lives, much, much less about politics, social activism. None of that was in my training program. And now these therapists come in with that as at the forefront. So, how are the clients being harmed by the system? How are they marginalized? Where are they unsafe? What accommodations do they need? And how can the therapists validate that? How can we accommodate? How can we sort of save them from the oppression that they're experiencing? Much less exploration of relationship patterns, trauma, um, which makes the new therapists honestly much, not even naive, but nervous, right? Like they don't have some grounded skills to rely on. It feels like they're being thrown into some sort of place where they have to be a savior. And of course, that's not their place and they don't know how to do it.
I mean, that sounds a lot like what we see in the clinicians, this idea that um, it's really about their role as an advocate and a savior,
Hmm.
and really relinquishing that role for any kind of exploratory guidance or really what's objectively in the best interest of the patient.
Hmm.
Um,
Yeah.
It
Yeah.
also it also denies the patient's agency when when therapists see themselves as rescuers.
Hmm.
well, and of course, if you need rescuing, it's because you are a victim or weak or threatened or fragile. Um, it comes with a whole lot of other aspects. Um,
Hmm.
so, do either of you think the gender affirming model has been aided and abetted by the greater emphasis in healthcare on patient autonomy? So, the idea that the patient must be empowered to make his or her decisions.
Yeah, without question. I mean, you were sort of just alluding to that. I mean, we've taken this good idea, which is patient autonomy, and completely perverted it. Instead of respecting patients enough to engage them in this careful evaluation and honest dialogue, we've surrendered our professional judgment based on research to the hands of children, right? Where people are coming in with their own self diagnosis, kids are, and the therapy field is following in suit, right? There's lots of, I mean, the readiness letters are one example, but also accommodations for schools and workplaces. We take the client's learned diagnosis, usually from TikTok, right? And we see these in trends of spectrum disorders and transgender identity, um, and then affirm and accommodate them. So we've really leaned way, way too far into allowing the patient autonomy, which is an incredible and hurtful burden for any patient, child or adult.
So,
You know, yeah.
yeah, so you mentioned letters. Can you go back and just talk about what letters you're referring to?
Yeah, the readiness letters that trans clients are asking for so that they can give those to gender medical clinics for medical interventions like hormones or puberty blockers or surgeries.
Okay. Uh,
Hmm.
so, we have, it sounds like, a much more consumerist model
Mm.
at work.
Hmm.
Just, in general, in our country, culture, also in medicine, very similar move there, because now we think of the patient as a customer, and of course, the customer is always right, but we don't hear about therapists referring anorexics to physicians who will prescribe Ozempic. You don't see this in other fields. This feels really unique to this particular diagnosis of gender dysphoria.
I'll push back on that a little bit. Yes, for the I don't think there's anything else where it's so consumer driven and also considered medically necessary life-saving care. Um, but I'm trained in EMDR, and I have people who will call me and they will tell me they want EMDR. I don't know what their problem is. I haven't even consulted with them, and they're already requesting a specific type of therapy.
Yeah, this reminds me of, people who see ads in, whatever they're
Mhm.
reading for drugs and go to the
Right.
doctor and say, well, can you prescribe me this particular thing? And I think doctors more and
Mm.
more just do it because they don't want poor ratings. And, maybe there's
Mhm.
a reasonable, they're not going to give them, something that's dangerous, but, I'll try this
Yeah, but
antidepressant.
even the ratings that's part of that
Yeah.
consumerist mindset.
Yeah.
Mhm, mhm,
And is this a case of supply driving demand? Um, these medical interventions are available, so I must need them because, now you can literally just order hormones from Plume or, it's like buying
mhm.
something on Amazon.
Absolutely, supply and demand. Yeah. Well, I mean, yeah, I mean, there's a larger conversation to be had there about pharmaceutical companies and the extraordinary amounts of money that are being made off of transitioning people. Um, but the demand is, like I was saying, like surged a couple years ago, and it's still there. So there's this there's a ready to serve kind of mentality in the field and in the pharmaceutical field.
So if those interventions weren't, you know, say legislation made those interventions no longer available, so kids are no longer able to just get puberty blockers or, surgeries, um, to look how they want. If that was no longer an option, would the sense of needing to alter their body also figure
Hmm.
out, fizzle out?
I think it would. I absolutely think it would. I think that a lot of this is an adolescent phase. And without being endorsed as a medical, with medical options, kids would have to tolerate the uncomfortability of puberty, inclusion, exclusion at school, and they would largely, as we see when people desist, come out the other side of puberty and become more comfortable in their bodies and get to shed this persona of being trans. So I absolutely think the demand would diminish.
And even given the kind of the culture around this and the kind of celebration of this identity, if you take that into consideration, is it enough to just remove the medical or delay the medical aspects of it? Because if they're 18, all of a sudden they can do this, given also who comprises this population. You've got some very rigid, fixated
Mhm.
kids with a lot of support and encouragement promoting this. You still hold to that?
I do. I do because I've seen it in my practice. I've seen my therapist work very neutrally, very carefully with some kids who identify as trans who start to, hardly ever bring it up and start to go by their original name again. Um, I know what you're saying, that it's celebrated and it's encouraged, and that there can be a real stringent attachment to it. And certainly there would be some people who would persist. But I think the social activism would probably find another home as it does, um, another group to save maybe, and leave some of these kids alone.
Mm. Yeah, I'm a little nervous about what that next
Yeah.
group is
Mhm.
and what they'll be pushing. Um, so, Jenny, let's talk about empathy. sounds like such a beautiful word, but empathy can at times be toxic. So Abigail Schreier, in her book Bad Therapy, argues that our society, and schools in particular, are encouraging kids to ruminate about their feelings. Parents are quick to sympathize and relieve their child's distress. So is the gender affirming model part of that bigger picture? Are therapists being too empathetic in general?
I think that's part of it. I I think it's more about I think it's more about therapists being very uncomfortable with sitting with distress that cannot be solved. I mean, it's this affirmation model. One, it affirms the therapist's sense of being a good person. And then there are also steps that you can give your patient. You can go to this clinic and you can do these things and you can relieve your distress. I think some of it is empathy, but I think a larger part of it is an unwillingness to sit with people in deep distress when there is not an easy solution and let that go on for a while. I mean, real empathy isn't just helping a person to relieve distress right here, right now. Real empathy is going to look beyond the present moment. It's going to, somebody who has a lot of empathy for the patient in front of them is going to think about that patient 5 years from now, 10 years from now, 20 years from now. And real empathy would take into consideration how these medical interventions could potentially negatively affect romantic relationships, the health of the patient, um, all of these different factors. So I get where you're coming from. I think people really have this focus right now on being kind, but I think more of that is an unwillingness to sit with distress of the people in front of them, and also an unwillingness to say something and to push back against this trend, because I think that there are actually a lot more people who have our opinions, but they're unwilling to say it, and I don't think that's empathy.
So, it seems to me like therapy is about, to a certain extent, sitting with discomfort, and or certain aspects of therapy, sitting with discomfort, learning how to navigate that and manage it. And so it's strange to hear that this would be so distressing for a therapist when I would think that would be core to the training and core to the process.
I think it used to be core to the training. Um, but one thing that's a problem, and I know Joe Burgo mentioned this when you had a space with him, training programs are not training new clinicians to be robust clinicians. There's a big focus on um, quick solutions. There's a big focus on reducing or eliminating symptoms, as opposed to a much longer focus of helping a person understand who they are, understand their internal conflicts, explore their thoughts, explore their feelings, and through that work of exploration, be able to have more choice about what they do in their lives. So, part of this is also really bad training programs that are run by people who often aren't practicing. I know when I went to grad school, most of the people who taught me had not practiced recently, or if they had, they were doctoral students and they had maybe 2 to 3 years of experience in the field. So, yeah, sitting with somebody's discomfort should be something therapists are able to do. But because of poor training, you see people who are newer in the field who have a really hard time with it, and they want to fix it, they want to change things, and that, again, that's a very empathic response. You see somebody in distress, you want to help them, but there are limits to things that we can do as therapists to help people need to have an understanding of how they are contributing to their problems, and once they have that understanding, they can make some changes that help them.
Um, so um, let's get back to thinking about the profession itself, or stick with the profession itself. Um, can you give us a general sense of the profile of your fellow students? This is for Jenny, who were preparing to become therapists. And Brooke, tell us if you notice the same with interns in your group practice.
So most of my fellow students were pretty young. This is a second career for me. So I went back to school in middle age. Most of my fellow students were in their early, maybe mid 20s, and they typically went from high school to undergrad to graduate school. So they didn't have a lot of full time work experience. Um, they might have had some brief experience working in community mental health or working for nonprofits, but they were pretty young. It was very heavily female. I would say it was 80 to 85% female. Um, Most were very liberal. When I was in grad school, this was during the 2016 election, and people were really distraught that Trump had won that election. Most people were very vocally against Trump. Um, and they were very certain that their beliefs were correct and that disagreement equaled hatred. It was really difficult. It was difficult for me to wrap my head around why somebody would vote for Trump. It was difficult for me to wrap my head around how somebody could be in this field and not liberal. And things have changed in the course of my professional development in terms of being able to take people's perceptions into account and really wrap my head around that. Um, but yeah, a lot of my classmates were very young, female, very liberal.
Okay, and
Mm.
Brooke, were you seeing the same thing with your interns?
Yeah, it's the same profile. I mean, I think young, white, female, middle class um, students dominate probably almost every therapy program, whether it's master's or doctorate level. And that identity is so vulnerable to many things, but currently to, guilt of being white and being privileged. So the response is to be an ally, right? Or to be serving. Um, and there's good intentions. And, I think it's okay that it's more women who want to go into therapy. There's a natural caretaking in the feminine, but it's over recruited and hijacked into this savior complex that we were talking about earlier. So, yeah, it's the same profile, afraid of doing something wrong, being activists before being clinicians. And luckily, I've figured out a way now in my practice to sort of advertise myself as not being part of that game. So I'm getting more critical thinking, independent young therapists who are resisting some of that affirmation model and doing amazing exploratory work with clients.
And what does that look like? Do you see an upswell in students like that who are seeing that maybe something's amiss here?
A little bit. Like, yes, I could say yes, a little bit. There are every year, like in the last 4 years, right? Just a couple more interns I get during the application process who somehow, will signal to me and we figure out that they're not on board um, with the gender ideology. But it's slow. Like even this last round, I'm very upfront. I tell people I'm not in the transing business. I'm not signing readiness letters. Like we're not doing affirming work here. Um, and most of the interns, had a hard time sitting with that. That's someone was saying that. And yeah, but I get people who come to me now because they know that that's the work I'm doing. I would say to answer your question, it's slow,
Slow.
but it
Yeah.
is, yeah, but it is moving in the right direction. But you know, we're nowhere near. we're nowhere near where it needs to be.
So interns see that you have a program that um, they can apply for, and do, so word is out then that interns would say, "Oh, avoid um, uh, Brooke Laufer because
Mhm.
she's not a friend." Like, is that word on the street for getting?
I would love to know. Oh, I'm sure. I'm sure I'm listed somewhere as a TERF
Mhm.
and transphobic or something. Um, I I don't know if, I haven't really heard that. That hasn't gotten back to me, but I imagine that's true. I think there's some word of mouth, especially through like therapy first. Someone will give my name, um, or different organizations. Like, she has a practice that's not affirming and takes interns.
Okay. We'll come back to this topic a little bit later about fallout and reputation, but let's talk about the children that come in. So, children as young as kindergarten are now introduced to this ideology in school. So, Jenny, do younger therapists just assume that every human has a gender identity and it may not, or it might align with their body? You know, is this just kind of assumed the way water is? What is this just the baseline now?
I think it is. But it could also be that people go along with that because they are afraid to speak up and say that they disagree when it seems like everybody agrees with that. I know when I was in graduate school, it really did seem like everybody believed this. And so I don't know if this was the natural result of, and I don't even know if my classmates would have been exposed to gender ideology in middle school or high school. They may not have been. Um, but it really did seem like everybody believed this, and there were maybe only uh, two, maybe three people who had questions about it. But again, when you look at this demographic that's in the field and in training programs right now, young middle class white women, this is a very agreeable type of person who might think differently internally and just not say anything. So it's really hard. It's hard for me to know.
Okay. And what about the impact on the patients and the young people that you see, or who are seeking this kind of care? What does that exposure at these young ages do um, developmentally to these kids?
I think it's really destabilizing. Um, it again. I'm very middle aged. I grew up in the free to be you and me time where we knew girls could have short hair and ride bikes and be tomboys, and they were still girls, and things weren't as I don't think things were as flexible with boys when I was growing up. You know, people would still make fun of boys if they liked girly things, but we grew up knowing that your sex isn't going to change, and ultimately there isn't a right or wrong way to be a girl or a boy, and that's not the message that kids are getting right now. And so I think that's very destabilizing. One developmental stage that kids go through is sex constancy. Um, prior to, I can't remember what age, um, probably around 4 or 5, Brooke might be
Mhm.
able to,
Yeah, that's what I was going to
about
say.
4 or 5. If
Mhm.
you show a young kid, you know, a picture of a boy and a picture of a girl, they'll know which one's a boy and a girl. But if you put a purse in the boy's hand or you put a wig on the boy, they will say that's a girl because they haven't established sex constancy yet. It is a stage of development. And so if we are teaching kids that you can be a boy or girl, both or neither, you are interrupting a developmental stage for children. That's incredibly destabilizing.
Mhm.
And when you say destabilizing, can you describe like a little bit deeper? What does that mean to destabilize a child? What does it mean for their understanding of themselves or the world around them?
Well, they won't have a solid foundation to stand on of I can be a girl who wants to have short hair and really likes playing with trucks and likes to play in the dirt. Instead, this person is going to be questioning, like, if I like this, does that mean I'm a boy? If I'm really a boy, do I need to, change my name? Do I need to change this about myself? Do I need to try to control all of the other people around me so that they see me as a boy? This is not a healthy way to live.
Mm. Yeah, I can speak to that really briefly too. I mean, children will wet their beds more, have more nightmares, or act out more, right? Like they are losing sense of self boundaries. There's a lot more fear because the ground has been destabilized. Like, it's been shaken. For adolescents, that'll be like more acting out, less trust and respect for authority, right? More school refusal, because we're messing with their instincts, very primal things about being human, where we have to sense the reality of opposite genders and telling them, like, no, what you see isn't real, and what your body parts tell you don't really mean what you think they mean. So it's I destabilizing, I get, is sort of a theoretical term, but it can have a lot of behavioral and physical results that are can be really devastating and scary.
So, I mean, you get this impression from the people who are promoting this that this is kind of a brave new world, that now for us it seems destabilizing. But if everyone would just see the world this way and come to accept it, that, that would be fine, that would be better because then people could be what they wanted to be at any point. That our way of thinking about things is somehow old fashioned or um
Hmm.
archaic, quaint or something.
Hmm.
Do you think there's
Sure.
a possible world, I guess I'm asking, is there a possible world where this is not a negative, it's not destabilizing, but it's just a new way of being that's healthy in some way?
Jenny, do you want to take that?
So are you saying, I want to make sure I'm understanding the question. Are you saying that is it possible for society to change where where we see this desire to change sex and to have medical interventions as just part of a new world?
Yeah. Yeah,
Hmm.
exactly.
I don't know. I don't think it's possible. One, you can't control other people's thoughts as much as people try to. Um, and two, going back to what Brooke said, you we're mammals. We have instincts, and we have instincts for a reason. And this is flying in the face of our instincts. So I don't think this would naturally move into, and this is a new world, and now society is different, and it's totally fine if people want to um, have really extreme body modifications. And again, I am pro people's autonomy. If you want to do that, do that. I don't think it's medically necessary life-saving care, and I don't think it should be advertised as such. But I don't think this is something that would naturally move into, and now it's a new world, and boy, we used to be really quaint back then.
I mean, not to mention that people who live as transgender are chronic medical patients. I
Hmm.
mean, there's so many problems. It's not in the service of survival and evolution. I
No.
mean, it really takes the body down. Um, Very difficult to have children, very difficult to live long, healthy lives. I mean, if yeah, there's no new world. It's going to be a shorter. stint for people who transition.
A shorter stint, and also you are really limiting your dating pool and the possibility of having a romantic and sexual relationship, which is another thing that's key for healthy life.
Hmm.
So let's talk a little bit about that. So you obviously you see patients who have adopted a trans identity, either adolescents or maybe older people. You know, is there a way? Are these people thriving? Let's start, Brooke. Let's start with
Yeah, I mean, so I have a couple and one long-term client who's transgender, um, and that person has openly said to me, I wouldn't recommend this to anyone. Like I would tell the kids of today not to do this. Um, like I was saying, just a lifelong medical patient, so many appointments, so much frustration. Um, deep insecurities about, like Jenny was saying, dating. There's still a belief, that this is the way this person identifies, this gender, which is not the one assigned to them at birth. But there's nothing at ease about it. And like I said, they wouldn't prescribe this for anyone. Um, so I personally, but of course I'm biased because of the work that I do, don't know any success cases. Um, the detransitioners are some of the most traumatized people I've ever seen, and I've worked with, major trauma in the past. Um, so I don't see, yeah, a positive way through for a lot of these folks.
okay.
I don't, yeah. Does that answer your
Yeah,
question,
it does. Brooke, do you want to talk about your impressions? Sorry, Jenny.
Jenny?
Yeah.
Mhm. Yeah, so I started getting into this work about 2 years ago, and I've only worked with a handful of people. Um, I certainly would not use the word thriving in describing them. There are a lot of other issues, many of which are way more important than gender. So, drug use, um, difficulties with friendships, um, self injury. There are other things happening. Um, and again, I've only had a handful of patients, so it's such a small sample size that for me to say yes, I've worked with them, but nobody's thriving. It's a very small sample size that I have.
Hmm. Hmm.
Yeah. I mean, it just seems like this existence would be, you know, baseline difficult because you're working quite hard all the time to maintain an identity that's not real.
Right. And there's a lot of work that goes into there's a lot of worry about people's perceptions. And you can't control that.
Hmm.
And so in my mind, somebody who can who can come to a point where they say, you know what, I know that there are trade-offs to pursuing medicalization. If they're really aware of what those trade-offs are, and they still think on balance life would be better, and they understand that not everybody will perceive them as the gender they're presenting themselves as, that would be a healthier way to go through life if you were to pursue something like this. Um,
Hmm.
my patients really have difficulties with the fact that other people may see them as their actual sex, not as the gender they're presenting as.
Yeah, that sounds exhausting.
Hmm. Yeah, it really is.
Hmm. Hmm.
And, hard to keep up. I mean, I think about what it takes for these I mean, obviously boys and girls are different, but these young men who, you know, classic case, they can't clean their room, they, aren't great with personal hygiene, but they're going to start wearing makeup and walking a certain way and talking a certain way and keep that up all their waking hours when they're interacting with other people, that just would a burden. The world
Mhm.
is
Mm,
already, maybe it's easier when you're younger. You don't have taxes to worry about and a mortgage and all these things. But once life starts becoming real, it just seems, just a
mhm,
lot of work.
mhm,
And that's when I listen to like podcasts or I watch videos of people who have detransitioned. One thing that they will mention is, this constant mental load of dealing with this and how taxing that is. They're some people have said that their gender dysphoria got worse after transitioning.
mm,
So, um, let's shift a little bit and talk to your clinical practice. So, Brooke, what is your approach to a patient who comes in thinking he or she has a gender identity and that doesn't align with their sex?
mhm. So I do, normal exploratory therapy, very compassionate, acknowledging that there may be some dysphoria, that something doesn't feel right, right? Like I'm not going to go out of my way to convince someone that a boy can't be a girl or a girl can't be a boy, but I'm also not sort of colluding with a delusion that someone can change sex and be happier, right? Like we're trying to find meaning and underlying factors into what might be driving some of this. Talking about past trauma or social patterns or influences, developmental issues. Um, what does puberty feel like? What does your body feel like? What are your parents like? How do you feel around them? What's really happening? What are you really looking at on your phone? These kinds of things, and unpacking what's behind the gender dysphoria and not accepting it at face value, right? So just like Jenny mentioned earlier, if there was body dysmorphia or anorexia or eating disorder, we could spend forever talking about like how much did you eat today, and yeah, there's ways to have a tummy tuck or Ozempic, and you can take care of that, but we should find out all the feelings you had like right before you ate and all the feelings you had right after and what it feels like to look in the mirror and what your mom says to you about your body, et cetera, et cetera. And a lot of what we're talking about now in my practice with some of these young adults who are exploring their gender is not talking about gender at all, right? Like just talking about what's going on in their lives, who their friends are, what school is like, and trying to unravel some, maybe sexual trauma that they're tiptoeing around. So sometimes it's better to not even go there with the gender. Um, and it does, especially for some adolescents, like a certain type of adolescent, right, who's maybe the artsy theater kid who was looking for a way to get an immediate inclusive community by being trans. Once they feel better in their bodies, they're not talking about it. They have a good attachment with a therapist. They're feeling better about themselves. They don't need that identity. So those are some of the ways that I try to approach it.
Okay, Brooke, do you want to talk about your practice? Sorry. Again, Jenny.
Jenny. That's
That's okay.
okay.
We
Yeah.
understand.
Yeah, it's similar to Brooke. Like I said, I have just a handful of patients with this, but um, it's not that often that we're talking about gender. There are a lot of other issues. Friends, difficulty with friendships, um, internalized homophobia, some of the messages that people
Mm,
may have received from
mhm,
family or their church community about being gay, and how that affects their self image. Um, self injury, again, looking at like
mhm,
what was happening before you decided to self injure. Um, what feelings were coming up? What were you hoping you would feel as a result of engaging in self injury? What else could you do? Um, working on that. there's a lot of times people want to talk about gender a lot when they start, and yeah, it kind of it gradually becomes less important in therapy as some of the underlying issues start being
Mhm.
explored. But a person has to be open to
Mhm.
working on those underlying issues and open to working with a therapist who isn't just going to blindly affirm.
Well, this is something that Joe Berger, that we talked about with Joe Berger, was, um, can you have engage in meaningful therapy if the client is resistant or comes there? I'm coming to you because I want you to write a letter, or want you to tell my parents that I should be on hormones, or whatever their goal is, or they're just resistant to opening up about this aspect. Can it still be helpful to these young people?
I think absolutely. Absolutely. I mean, I would immediately tell someone I don't write letters, but I really want to know what's going on with you. I would love to know more about how you're feeling and just figure some of this stuff out. I mean, I certainly set aside and tell my therapists, my interns too, to set aside any feelings or thoughts they have about affirming. If a lot of them think that it's harmful, like set it aside, be very neutral and just be with a client. I think even if a client is like, you should be telling me that I should be a girl, and you can still work with that like you can with any other sort of combative client, right?
Mhm.
There's a lot of good relational material there. I mean, if a client just leaves, there's nothing you can do about that. But if you have a good therapist who can form that relationship outside the letter writing, setting that aside, I do think a lot of good work could be done.
Okay. I'll- you mentioned that, building that relationship. I know parents have talked about this, where they'll find a therapist, and the therapist will use the pronouns, use the name, and they'll say, well, this is necessary for us to develop this relationship where the young person trusts me. Is that a reasonable approach to these young people?
I don't think so.
I don't think so either.
um,
No.
I rarely use my patients' first names in session in general. Once in a great while, I might, but with my gender patients, I avoid the first name. Um, I've gotten really good at not using pronouns, and that's not something that I would normally use in any session anyway, because I'm working one on one with somebody. The only pronoun I would use is you. Um, but I don't think that fosters that relationship. I think that is a quick, easy trick that some people might use to foster attachment and relationship, but that doesn't. I think you can work on developing that relationship in other ways. And some of those other ways would be, being curious, being attentive, being willing to work with the person, and being neutral. So not putting your thumb on the scale.
Hmm. In fact, we're doing some of the opposite work where maybe parents, out of fear, have been using other pronouns or other names for their kids that the kid has asked them to. But in therapy, a therapist will use their given name or their true pronouns, and then also work with the parents to start to return to using the true name and true pronouns, and reintegrating that in a safe and understood way, right? Like getting back into reality where the parents have just been in a state of fear and doing what they think they should do. So, yeah, I am really committed to, the common sense, the reality. Like, this is your name. Like, this is what I'm going to call you. These are your pronouns. And like Jenny said, it really doesn't come up when you're doing one on one work anyway.
Mhm.
Yeah. I,
And when it does, like most of my patients are adults. My gender patients are adults, but there have been times when in a session with somebody, especially if because I work with young adults, one of the things that we do is like make phone calls together because it's really hard when you are 20 years old to know how to call an insurance company and get information. There are some life skills that they don't have that we sometimes work on in during the therapy session. And there have been some times when I used the, I'm just going to say, correct pronoun of the person in front of me, and there was a reaction. And after that phone calls, maybe we can explore that. What was that like for you when you heard me say she? What was that like for you? What feelings came up? And you can help them explore that and express that, because one other thing that's happening in gender is they're communicating something, and they're doing it in their actions instead of words. And so working on helping them express their feelings and their thoughts may help them move away from just acting them out.
do most of your patients come to this ideology through the usual routes that we've heard about over the past several years, in school, or they got online and took a test, oh, you're trans test, or through peers, they're sometimes on the spectrum, survivors of trauma, sometimes sexual trauma. Is this, are you seeing, is this kind of still really the case now?
What do you mean, the people seeking therapy
Yeah, or
because
young people who are falling into this, so, and then seeing you. I- how are they getting to this point? What's the
mm,
precipitating factor?
mhm. Yeah, I think a lot of it is middle school social um social difficulties and then social contagion. So having distress with their bodies, with their identity and with themselves, and then being in a culture of, where this is a trend and this is a way out of that. The culture of having a therapist has become so much more popular, even
Hmm.
for kids who aren't trans, right? So any kid now who has a phone and who's looking at TikTok like thinks they need a therapist, especially if they're middle or upper class. So just floods of adolescents have come into therapy, I would say, in the last decade. And so this is a part of it.
Mm, yeah, yeah.
Yeah, and
Go ahead.
for my patients, very heavy internet use. Um, Coming across this through internet use, it's also pushed in school. The story I tend to hear from patients is, I always felt this way. I just didn't have the words to express it. I didn't have the language. Um, from their parents, the story is they were never like this until, usually it was until COVID, and heavy internet use. And then, between schools pushing this and a lot of internet use, and there's bullying, or starting to understand that you may be bisexual or gay. Those are all things that contribute.
Mm-hmm. Okay, so the standard picture of these young people
Hmm.
still holds. Um, so let's go back to the profession a bit. Both of you see yourselves as outliers in the field, so you're a minority among your clients, your colleagues. You both had experienced professional pushback. Jenny, I believe someone filed complaint against you, against your license, because you posted webinars by Therapy First. What will it take for, first, tell us a little bit about that experience, and then what do you think it's going to take to get the profession back to common sense?
Yeah, so I had 8 people file complaints against my license last year, none of whom were patients. I've never treated them. Actually, I don't know any of them. Um, I am on a therapist listserv, and therapist listservs are usually people who are looking for, referrals, like, I have a patient who's moving to a different state. Does anybody know somebody, a trusted colleague who might work with them? Or, here's a webinar, some training is coming up, things like that. So on this particular listserv that I'm part of, I will post webinars that are hosted by an organization called Therapy First, which I'm part of. And it's an organization that advocates for basically psychotherapy as a first line treatment for people with any kind of gender distress. So these people on the listserv, when I posted a webinar about trauma-informed mind-body practices, and several people said that they were going to file complaints against my license, and they did. Nothing came of it. I had my lawyer contact my licensing board about it, and they dropped it within a week. So there was no disciplinary measures taken. But it was a stressful experience. It was an unnecessary stress, and it's I see it as a way for these people to get people like me to shut up, because there is a false consensus that this is evidence-based life-saving care. And there isn't an evidence base for this affirmation model. So when it comes to getting the profession back on track, a number of things are going to happen. First and foremost, every single therapist who has concerns about this or has doubts about this needs to grow a spine and speak up. And you don't have to shout it from the mountaintops, but every single person needs to start saying, I have concerns about this. I've looked into this. I think we might be harming people. If people start doing that, there won't be this sense of a consensus in the field. Lawsuits will likely help, but that's putting a really big burden on people who have already been harmed by transition. Not everybody who has undergone medical transition wants to take on the stress of filing a lawsuit. It's really difficult for people. But I am hoping that lawsuits help, that people will start to consider what it is that they have been taught. Because again, this is something that it is taught in training programs. It is taught in pretty much every continuing education event that I've gone to about trans issues. The affirmation is being taught as, this is the right way to do this. And if you don't do this, you are hurting people. And when you are telling that to a group of, a lot of times, very agreeable people, they're going to go along with it. So we need people who have concerns to speak up. We need organizations like Therapy First that provide training, that help people to really look at their patients in a very in the complex ways, and really look at all of the different factors that are contributing to their distress, and help them. Brooke, I'm going to hand that over to you because I'm not sure where else to go.
Yeah, I mean, ditto everything you're saying. I would love to see more detransitioners start to file lawsuits, but like I said, these are really broken people. But I do hope they get their moment to stand up and announce what wrong had been done to them. Um, like I said, I do see a slight trend starting where we're able to talk more openly about this. There's more and more clinicians on the Therapy First directory. I can talk more openly just in some of my circles, or like with my dentist the other day, with just less fear of being canceled. Um, yeah, I think people have to lose the fear and just be more honest about what is really happening, what they really see.
There's so I guess I would ask, it sounds like you're seeing some cracks in the ice
Mm-hmm.
there.
Mm-hmm.
And I assume that means you've got more people speaking to you as well as being able to speak to them. Um, are, are so does being in Illinois, the land of Pritzker, make this any particularly more difficult? Is it just that being in a blue state? And do you feel additional kind of pressure from politically there?
I certainly do because it's so much a part of the schools in the Chicago area, which I think
Mhm,
has a large part to do with Pritzker and Lurie, which is the gender clinic, which is, of course, connected to Pritzker's family.
mhm.
Um, and so it's infused into the curriculum. So it is the monolith, and it is hard to push back against it. Most therapists really funnel, kids, young adults to the gender clinic at Lurie or to Howard Brown, and they get very easy, within one 45-minute session, they get a year's worth of hormones prescribed to them. Like, that's very real, and that's happening all the time. So we're working, it's uphill for sure in Illinois and Chicago. But I think it's just common sense and it's instinctual. So if you can approach someone or speak in a real and non-defensive and non-combative way, I do find that more people are able to hear the things I'm saying, especially because I can say, I've seen the harm that's being done, and that's so real.
Do you have a particular fear? So, this term conversion therapy has been um, tied to exploratory therapy now, but it's a particular kind of damage, right? That someone would be doing. Do you have concerns about being accused of conversion therapy specifically?
I've already been accused of it,
Yeah.
so it's um, yeah, I've already been accused of it, but
Mhm.
the therapy I do is it's just regular therapy.
Mhm.
I have well, I just terminated with one client, but up until recently, I have I had 2 clients on hormones. I don't tell them not to take hormones. I don't tell them to take hormones. These are adults. They can make
Mhm.
decisions for themselves. We can look at their perceptions of, what they see as benefits and risks. We can talk about that. Um, but ultimately, I respect my patient's autonomy. And y- I'm certainly not trying to convert them one way or another. Um, but yeah, I've lost my fear of being called a conversion therapist because I've already been called it.
Mhm.
And I've already had my fears came true. I was really scared that people would file complaints against my license. And it happened. And I got through it. And it is a pain in the butt. It was unnecessary stress. There were legal fees involved because I had my lawyer deal with it for me. But again, I want to go back to therapists need to grow a spine.
Mhm.
Um, yeah, people are going to call you bad names. Um, yeah, people are not going to like you, but there are more important matters here.
Mhm.
Think about like exploratory therapy and the true meaning of that. I imagine that you have parents coming to you saying, "Fix my kid. My kid's trans identified. Talk him or her out of it." Their expectation is very specific. So, how do you deal with a parent who comes to you with that goal, singular goal, which I think a rational parent would, but it's still quite a force to be reckoned with, maybe, or maybe it's not really part of the therapeutic goal to a certain extent.
Mhm. Yeah, that's some of the uh, more anguishing work, I would say, like parents who are just terrified watching their kids tell them they want to identify as opposite sex and start transitioning. So, most important, I think, is having the parents in therapy. The parents need support. The parents need to figure out their boundaries and strengthen their spines. The children act like dictators in the home, and the parents really need to take back some power. So I think it's essential that the parents are in therapy. And then we work with the kids in a very neutral way. So, not announcing ourselves as affirming or non affirming, right? But just very curious about who this kid is and what's going on with them. And then, trying to work with the parents and the kids together where we can find common ground, um, and not move towards the path of affirming, to either just
Mhm.
pause or to rewind.
Mhm. Okay.
Yeah, and because I work with adults, um, it's usually a parent or the parents who contact me, and I know that there's typically it's either explicitly said or it's implied that they would like for me to talk their adult child out of this, and I'm really explicit with them that that's not my job, that's not what I do. Um, I'm here to help them explore how they feel and the different factors that contributed to that, and work on some of the underlying issues, but um I can't guarantee any outcome, and ultimately, again, I go back to respecting my clients' autonomy, and adults are able to make choices for themselves.
Okay. Um, so we'll broaden this a bit. The whole issue has become politicized. We obviously at DIAG see that and are trying to shift that narrative around this being a left right issue. The Democrats have framed trans rights as the latest civil rights frontier. Donald Trump responded with his executive orders on biological sex and gender medicine and women's rights. So now we have Democrats in Colorado really doubling down, likely in response. So last week, the state house gave preliminary approval to a bill that would require schools to use preferred pronouns and would punish parents in custody battles who don't affirm their kids, kind of paints them as abusers. So, what does that mean for non affirming therapists in Colorado? And does that set, if it passes in the state, does it set a precedent for other blue states? Is this a concern? So from both of you, let's start with Jenny on this.
Yeah, this is a really big concern. Anytime you interfere with the parent-child relationship, you only do that in egregious cases of abuse. Um, it's going to be far more damaging for children to have that relationship interrupted by the state because the state sees the parent as an abuser than it would be for them to have parents who aren't going along with name and pronouns. This is really overstepping bounds. And I don't know how a therapist who operates from a more neutral, exploratory stance is going to be able to operate when if that is the law.
Yeah, it seems like they would have to go further underground.
Hmm.
Um, about that happening in Illinois or in other blue states, I'm not sure. I mean, again, if there's some more lawsuits or some more disruptions in school, like what happened in Deerfield, where the
Hmm.
girls were made to change,
Yeah.
and that got the news, and some teachers were scolded, and parents are speaking out about their daughters not wanting to be in bathrooms with boys. I think that schools also respond to that because it's intuitive. So, yeah, I mean, I hope that there isn't more response to the executive orders. I guess I really don't know.
Well, and the other thing, we need more people like Jonah Wheeler. We need Democrats who are willing to speak up against this, because right now it's framed as this politically polarized issue instead of being framed as a medical and mental health treatment scandal.
Right. Well, when you have a split vote down party lines,
Right.
It's
Well,
it's impossible to frame
mhm,
it, near impossible to frame it as not a political issue because it's playing out as
yeah.
a political issue.
So then, just like my hope for therapists that they strengthen their spines, the Dems need to strengthen their spines and speak out. And
Mhm.
this is not going to go well politically. I mean, right now it's very scary, but truth will out.
Yeah, I wonder about the kind of the national consciousness around this, polarization in
Mm,
general, but about something so kind of dystopian and nightmarish, when
mm,
the US works its way out of this and you have one party that supported it and promoted it,
Hmm.
what does that do to our national, the psychology of our nation in a way?
mhm. Yeah, I think about that a lot. And I think that's in tandem to COVID too. Like we watched leadership disappoint the collective and make bad decisions, and they didn't help and they didn't do the right thing. And we have parents and providers who aren't doing the right thing. They're they're making huge laws that just keep hurting kids. There's going to be such a loss of trust in authority. And of course, it's like hitting bottom. I feel like this has to be the bottom, right? Where we're taking off young girls' breasts. And so there will then be the swing towards rules and standards again, which is of course what Trump is trying to do, and why he was put into office again, because there is the swell of wanting to correct this.
I do wonder about the fallout. What happens to a country where you have kind of a villain, right? What's the something this big and this obvious? So I wonder how that's going to play out. And what about your profession? Like, you talk about mistrust. I think we already have that in parents, right, who don't want to take their kids to the doctor, don't want to send them to college, don't want to do anything where their kids are going to get exposed and harmed by this ideology. And obviously, the therapy, the psychotherapeutic profession, is going to have fallout that is probably going to cause a lot of damage.
I don't know if there's going to be fallout though. I mean, there should be, but was
Hmm.
was there any fallout to the Satanic Panic?
But how many people
Hmm.
did this? We weren't
Yeah,
passing satanic panic policies
that's
or
true. Yeah,
telling parents
yeah.
they were abusive for not getting their kids,
Hmm.
you know, out of adult,
Hmm.
whatever.
Yeah, I don't think the profession will sort of dwindle. I mean, it would be great. Certainly, it may lose like a sense
Hmm.
of integrity, and it will take some time to recuperate. It would be great if we got ahead of it. If like the APA
Hmm.
got ahead of it and said, oh, wow, we saw the cast review. Like, we want to pause this. We are sorry. We are sorry it went this far. But before one more person gets hurt, we're going to pause this.
Yeah,
But it doesn't
yeah,
seem
that
Yeah, I was
likely.
going to
Yeah.
say there needs to be a reckoning. There would need to be an acknowledgement of wrongdoing, and I don't know if the APA or the ACA or NASW would do anything like that.
yeah. I mean, you mentioned the CAS report and that the American Psychological Association of one of the states, maybe Pennsylvania, basically said you couldn't post on their listserv, you couldn't discuss it on
Mhm.
their listserv. So, what does that environment look like? I mean, you've run into problems posting about therapy first on there. Is it a lot of chatter about this topic? Is it clear, is this a major issue in the psychotherapeutic world?
So I'll go first. It is a big issue. Um, it's not uncommon to see a couple of different webinars or trainings being posted on listservs every single week about trans affirming care, letter writing, getting training to write letters, or looking for somebody who could write a letter for surgery. Um, but again, I think there's a false consensus. There's this sense that everybody thinks a certain way because there is a minority of very vocal people.
Yeah.
It,
Yeah.
it's really hard to know. Like, I'll get back channel messages of support, but people don't post that support publicly. So there may be a lot of people who have different ideas, different opinions, or who have concerns, and they aren't voicing them.
Yeah, that has to change
Yeah,
to save the profession. I think that
yeah.
has to change across the board. Okay, let's shift and take some questions from one. Um, Social transition does not allow an off ramp to kids that get sucked into the ideology. So why are we saying this psychological intervention is okay? It is a form of gaslighting. And this person wanted your opinion on that.
Why are we saying psychotherapy is okay?
So,
Is that
Brooke, can we hear you? I'm
Yeah,
a little
can you
worried
hear
that we
me?
can't. Or,
Oh, are you
Oh.
saying why is social transition okay?
or it sounds like, yeah, why is this seen as a reasonable, you know, a reasonable psychological intervention, as if it's not harmful, as if it's not, doesn't keep the kids sucked in?
I agree with that. I think it does keep them sucked in. It's really difficult once you've made this big announcement to your friends and your family and you demand a name change and pronoun change. It's really difficult to walk that back. So I would be incredibly careful about social transition. I would again, I work with adults, but if I were working with adolescents, I would talk to parents about the potential downsides to that. It's a very powerful intervention.
Should mentally ill adults be allowed to alter and mutilate their bodies while delusional, a state in which they have limited capacity, which makes them unable to make rational decisions, all in the name of body autonomy? So maybe that's pushing back on whether body autonomy is really a valid reason to let people have access to these interventions.
I think I totally understand where that person is coming from. There are a lot of very vulnerable people who are pursuing these interventions. Um, there's this. Some people hold this belief that um, we really need to fight against this for the kids, but adults can make their own choices. And yeah, to some extent, that's true. Adults can make their own choices, and there are professionals who are abdicating their responsibility because of how this model works. So for example, if somebody wants surgery, they usually need a letter from their therapist. And so the therapist can write a letter and then they can assuage any feelings of, guilt or concern that they have by saying, "Well, I'm not the surgeon. I'm not the one who's performing the surgery." And the surgeon doesn't look at the mental health of the patient and is relying on this letter from the therapist, and they can say, "Well, I'm not the one who was evaluating their mental health, so that's not my job." All of the professionals abdicate their responsibility, and the only person left holding the bag is the patient, who oftentimes is a very vulnerable person who's struggling with a lot of mental health difficulties. So yeah, this is a valid question that this questioner had. And this is part of the problem that we get into when people who push the affirmation model talk about something called embodiment goals. I went to a training a couple of years ago, and the person was talking about affirming care, and I asked the question, and I asked knowing that they would have no answer for me. I said, what assessment do you use to determine who is going to persist in their trans identity and who will not? And the person said, oh, we don't really use that. We look at embodiment goals. So they just shifted the focus. So instead of assessing the person to see if this is an identity that's going to persist, we're just going to help them with their embodiment goals. But that's not medicine.
Yeah. Brooke, are you back with us now?
So it's sort of a question and something that I've pondered since my daughter was socially transitioned at school. We have kids that are living these dual lives, and as therapists, put this out there for all the therapists, are we thinking about the long-term effects on the brain and the development of a child that has been socially transitioned at school and then at home? For me, I never affirmed her. So they're splitting um, themselves and living a dual life, thinking about the long term effect of their cognitive development. Like for me, I see my daughter; she's almost playing catch up for the 2 years that she lost while the school was socially transitioning her.
Brooke, do you want to take
Yeah,
that?
sure. Yeah, I'm so sorry to hear that. I mean, this is really devastating stuff. And this, I sort of mentioned this earlier, there is an arrestment of development at transition. So it's like a trauma, where we look at trauma research on the brain when there's this sudden shock to the system. Sometimes developmental processes get paused. So there's not maturation that would happen then in the normal, I'm using air quotes, sense of the process. So sometimes people who've transitioned stay in a very immature, almost childlike state. And if they detransition, then we'll start the maturation process up again. I can't wait for more research to be done on this, but I just see it over and over again. And so, especially if she's living, well, she has one foot in reality, right, in the house, in your home, which
Mhm.
is which is good. I would think that's a good constant seed of health for her that hopefully she can then fully return to.
She
Um,
has desisted because
oh, okay.
I fought the school to stop socially transitioning her. So I got all the teachers and the administration, everybody to stop. And since then, she's been on her way back to herself. But I see
Mm,
almost like her playing catch up from what she probably would have experienced the first 2 years that they were doing it. One in secret, and then one they just blatantly did it without my consent as I was fighting them to stop.
yeah. Yeah, it's like they hijacked her executive functioning.
Mhm.
And I wonder if, someone in some way can explain that to her, if that would be helpful. So she sort of understands like the structure of what's happening. And I would have every reason to believe she would catch up, so to speak. Um, when she has like these safe places then to mature, even if
Mhm.
it's at, a different rate than her peers.
Do you think that there could be any long-term effects of the social transition on the developing brain?
Mm,
Or once they stop that and they start to desist or detransition that like you said, it will just start to heal and, you know, eventually they'll be delayed for a while and then catch up to their peers?
yeah, yeah. I understand your question, and of course I can't say definitively, but I
Mhm,
wouldn't think there's a long-term effects. I think if it gets understood and integrated, I mean, if it's shunned and, put a moratorium on speaking about it, and that was the time we cannot speak of, like, then that's going to be a trauma. But if we don't turn it into a trauma,
mhm.
I think that with insight and care, it can be integrated and there wouldn't necessarily be long-term effects. Hopefully as an adult, everyone can look back and laugh at it.
Right. That's sort of what she has done, like, don't speak about it and
Yeah.
just move forward. Yeah.
I'm going to go to
Thank
Sarah.
you.
Thank you.
All right. Hi, guys.
Hi.
So I just wanted to kind of state a couple things. Like one of the difficulties with these conversations and the importance of these conversations is kind of how complex these questions are, and then like lay down on the therapist, right? So, like in Lydia's circumstance, it's kind of like, okay, when we have a child that was affirmed from a school or a pediatrician or even a parent, disrupting that frame of understanding can disrupt a whole household, right? And I think like there isn't a simple answer to these questions in terms of, okay, we always do this no matter what. I mean, I think in my experience, in many people's experience, like we are stuck as clinicians by health insurance companies and our professional boards. I had to personally sign something that said I do not engage in conversion therapy. So a child, if I even asked a certain question, I could be charged with ethical code violation. My own profession has let me know that we affirm no matter what in anything related to exploratory care would be considered conversion therapy. What I do know is like working developmentally has helped these children understand what's going on with themselves and their choices. I mean, several kids that I work with that, for example, were sexually abused, had I pushed their need to identify as part male, I would probably disrupt their protective measures in order to get through what they needed to. And then after treatment, every single child went back to their natal name. I think again, we have to all kind of work together to recognize like the many levels that of stresses that people are in. And we're here talking to parents that don't affirm. I don't think other people are aware of us as therapists how many parents are the first one to affirm. So I have so many clients that go home to their parents, say I'm they them, and their parents are like, awesome, let's go to Target, get a binder and a pin, and that's it. That's the conversation. That's what's going on. So again, these are multi-layer areas that need a lot of care and a lot of thought, and it does go developmentally. And I don't know if, like what Brooke says, I agree that I hope with integration things would change and go back. But I would say that if there's a disruption in a major developmental stage in a kid's life, that's going to impact them later somewhere down the line, of course. And we have to be there to remind them and get them back on the stage and on focus. But I just think like some of these questions, I mean, I sort of jumped on. I mean, even these concepts of, do people believe in true trans? It's like, what's unfortunate is like most therapists believe that people are truly struggling and understand that there's a medical world that is making decisions beyond them. So it's very tricky. I wouldn't recommend body modification anymore as I would feel like I would recommend someone to tie their tubes. Like I would walk with them while they make these informed decisions, and any good therapist would probably do the same. Thank you.
Sarah, do you want to introduce yourself? I don't know if people knew that you were.
Sure, yeah. I'm Sarah Stockton. I am a licensed marriage and family therapist. I am a member of Therapy First, and I transitioned probably hundreds of children, and then changed my ways and now work with other organizations and whistleblowers and therapists to reinforce like the original developmental considerations to serving children and not intervening in adolescence or childhood.
And can you tell us what state you're in,
New York.
and how has your kind of vocal opposition to the affirmative model impacted you professionally?
So actually I was working and had a practice for over 10 years, and because I decided to speak up, because I did publish one of the first articles that helped children affirm, which was developmental and followed the WPATH guidelines. I was fired from my job at teaching for 14 years. I am blacklisted in the New York State. I've had many protests against me speaking up. And I have many local people calling for my death all the time.
Thank you for joining us, Sarah.
Yeah,
Yeah.
thank you.
Yeah, and I just think it's really difficult, because one of the pieces going through this, having a parent who like took their own life because of what was done to them, like in my practice and stuff, like I think the emphasis on what the parents are going through is so real, and yet we have to find a way to balance like fear, because when we go on fear, we make stupid decisions and act out, and this is what these kids are doing because they're so fearful of what's going on in their body, so like uncertain about, will they ever belong, will they ever, are they okay, are they born like that. Being afraid that you could be born wrong is like the most hyper vigilant state ever, and now these parents are in this hyper vigilant state, and we have to balance this for them, because like it's gonna take everyone to get through this. And so if somebody believes that a person that has had a trans identified life can't help these kids, then if these kids make these decisions, they might not think they can ever come back because they won't be welcome. Where are they going to be welcome back? Because they're going to need to rely on the same endocrinologist that gave them the hormones, and the same surgeons to fix them, and the same therapists to help them heal from their trauma. So it's like we all have to heal this together, and we can't prosecute people for the world that these kids were given.
Talking to Brooke and Jenny, they were never affirming. Their training was, well, certainly Brooks was not the strict affirmation model. But were you trained in the affirmation model, and what was your turning point? What precipitated your shift in understanding?
I mean, I guess in hindsight, you're going to call it an affirmative model. There was no term like GAC when I went to grad school in 2008. We were the first people to consider what was going on at the Dutch protocol, and we were asked to implement it in the United States. And my university had already been known for writing the hormone letters for adults and being the top people recommending medical transitioning for transsexuals at the time. And I say transsexuals because I was taught with a real emphasis of the importance of their biological sex. There was not a child that I ever recommended anything for that was like unaware, delusional, or not able to take care of their biological sex. It doesn't make it right. I'm just saying that that is a big jump that has happened. So this is 2009. I get published, and I'm working until probably when social media really comes to bear, jazz comes out, and then the rise in autism cases, and the rise in females. So when I started, I mean, 80% of my people were males going to identify as females, and then there was like a 300% shift within 5 years, and it was really unexplainable. And I also was able to say like no to people, but then there was the cases where it was like, oh, you know, I'm the fourth person in my friend group to identify it, and I wasn't allowed to question it, or people who were not showering but think they're going to be a female. So the thing started shifting. The major thing that shifted it was that I had a parent who brought in how puberty blockers were not FDA approved, which, as much as I was trained to get these children on puberty blockers, I was never trained myself that they were actually that risky. So I suggested to the courts, due to the parents' concern, because there wasn't a parent that I could not get to agree to transition their children, because this is all about trust, which is why it's scary for everyone, because we have to trust each other and all these people. And I asked the courts to hold off because this child was 10 and I thought the mother was Munchausen syndrome by proxy. And the court said overruled me, and the kid went on hormones and the father killed himself. And that one was kind of when I was like, oh, okay, I'm not doing what I'm doing anymore. This isn't, there's no safeguarding for these kids. There's no rails. It's gone. The rails are gone.
Wow.
And then I realized kids were also choosing to not be gay. And I was like, oh, I had gay clients coming back from like moving to LA and then had transitioned and never had gender identity issues and were just sucked in by this sexual drug lifestyle and making money, and then completely transitioned their bodies and were left to nothing. So yeah, I mean, there was a lot of moments, and so I kind of sat back and decided I'm just gonna focus on sex, and I work a lot with AGPs, as people would call them, or cross dressers. I mean, I think the reason why I was always kind of nuanced around this was because I have several clients who decide not to transition, so
Okay.
and have that sort of separate understanding of it. So I never thought of true trans. I don't think many clinicians do see it that way.
Yeah. All right. Well, thank you, Sarah. We appreciate you being here.
Thanks.
We're going to move to Gloria. You want to unmute and ask a question?
For many years, it was difficult to find an incident that I actually was almost a witness to, the murder of a therapist by a man who identified as trans in San Diego back in 1998. My partner was sharing an office with this therapist, and I went to pick my partner up, and as we drove away, the murder took place. So I would have been in the building at the time, in the office at the time, moments, if we didn't leave when we left. This murder suicide was covered up for many, many, many years. I've been searching for articles and information on it, and there are patients who do kill their therapists, and the statistics are that they're generally addicted, drug addicted, or something of that nature. But I just wanted you to be aware that there are a lot of things within this cult, I call it a cult, that are covered up, swept under the carpet, the misinformation, the lies, the emotional blackmail, the Be Kind Brigade. These people, I know you're all therapists, and I'm not a therapist. I've been in and out of therapy all my life, and I've always been interested in psychology. And I actually edited a book on post-traumatic stress disorder. When I was a teacher, people came to me and asked me to, they think that you're an editor because you correct papers. But anyway, I did this book, and I had to delve very, very deeply into the field. And I was in a relationship with a therapist. So I one of the things that I'm really concerned about is the misinformation, and also the way in which we discuss this topic. This movement is probably one of the greatest destructors to ever happen to our society at this point in history.
Um, Gloria, I want to get some impressions from our guests, but do you have a specific question that you want to ask?
Well, I'm hoping that um, the work that you're doing, and I'd like to be a little bit more involved in it, is going to make a difference. But without the proper information, I know you mentioned Pritzker. I posted the 11th blog. I think it's really important that people should read that, um, and get all the information to see how uh, this is what this is doing to kids. And I'm just wondering, do you feel like, I know the organization is in its infancy, and I'm a lifelong Democrat who had a real problem this election, which I'm sure a lot have. Do you feel like you're able to, not only nationally but internationally connect with other women and other people who are working to mitigate the effects of this horrible movement, cult?
Okay. So it sounds, thank you, Gloria, for your question. This sounds like a question for me, representing DIAG. We certainly do partner with other organizations. We work closely with the LGB Courage Coalition on certain actions. We're obviously we work with Wolf and WDI USA. So we do we're a lot of these organizations. There's other organizations that we're connected with either personally or through kind of the organizational sphere on this. So yep, we're in touch with a lot of the other groups and working hard to get some movement here. Um, we're going to, let's see, there was another request which somebody else, Learned Mama, go ahead.
Yeah, I was just curious about the mention of, how therapy is the first line for therapy first, giving people therapy, but what is the second line of defense when working with clients that are confused about their sex or dissociating from their sexed body by believing they're non binary or the opposite sex or wanting to have medical interventions? Do you see it as medical self harm? And if there are trans identified clinicians in therapy first, is that a conflict of interest?
Okay.
Well, I want to be really clear that Brooke and I are just speaking as two therapists. So we're not speaking for an organization that we happen to belong to.
Yeah, I think it's they certainly can't represent therapy first, but along those lines, I have the question of, you still have to carefully vet no matter where, who refers you to a therapist. You really do have to carefully vet these days. And do you have recommendations for parents about how to do that? How can you tell that you've found a therapist who is not going to rapidly affirm your child or recommend social transition or any of these other interventions?
Hmm.
Start with Brooke, go ahead.
Yeah, I mean, I tell people, you want to find someone who has a website that doesn't have flags and pronouns on it, that they're not, leading at least with the model, and that they have a basis in psychodynamic, psychoanalytic, um, orientation. If they haven't found someone in therapy first, I mean, I always refer people to therapy first because those therapists are vetted and And yes, there are transgender individuals in therapy first who are also against the ideology, just like my client. It's not about their personal stories necessarily, although of course it's related, but honestly pretty easy to spot the affirming model. And it's, if you don't find someone in therapy first, I try to go with, sort of the old school psychoanalytic, very neutral seeming therapist.
Yeah, I would add on to that. You'll probably have better luck if you are working with an older therapist who's completed his or her training quite a long time ago
Mhm.
before this became standard in training programs. And if you have these concerns, you can always bring them up openly and see how the therapist responds.
Let's see, do we have anyone else? We've already hit the 2-hour mark. So, unless there's other questions, I think we're going to wrap this up. I want to give a big thank you to Jenny Rogers, professional clinical counselor, and Brooke Laufer, clinical psychologist, both in practice in Illinois, both members of Therapy First. So thank you both for joining us. It's been a pleasure speaking with you.
Absolutely. This is
Yeah,
great.
thanks for having us.
Yeah.
Our pleasure. If you haven't already done so, please join DIAG by clicking the join button at di-ag.org. That's di-ag.org. Our power to reach our lawmakers is through our numbers. It's important to show that we are a silent majority who believe in classical liberal principles, following the science, including on the reality of sex, ethical, evidence-based medicine for all, the power of civil discourse and open dialogue, advocating for the rights of women and girls to sex-based spaces, honors and opportunity, LGBT rights, and the necessity of a compassionate, reality-based society where truth matters. Thank you all for joining us. Our next space, I believe, I'm not going to release the date yet, is going to be a recap of the current state of detrans lawsuits. So please join us for that. That should be a great one. Have a good rest of your evening. Take care, everyone.